Hi, everyone. Thank you so much for joining our session today. We are Pre-Health Shadowing. We are an international student-led nonprofit for medical advancement. So we are really passionate about the plethora of medical knowledge that exists in this world and getting more folks integrated into the field and learning about more specialties and career opportunities within the medical field as a whole. We do have closed captions available for all of our sessions. Our goal is to accommodate students of all abilities and needs. If you ever think we can do a better job of that or have any suggestions, please feel free to send us an email at info@prehealthshadowing.com. Just in general, that's how you would reach us all the time. We constantly have folks monitoring that email, so if you ever need to reach out or have any questions or any ways that we can improve, please let us know. If you want to stay in the loop with pre-health shadowing, we do have a variety of social media platforms that we post on frequently. Instagram, TikTok, X, Facebook, YouTube. Special shout out to LinkedIn if you're looking to expand your professional network. LinkedIn is a great way to do it and to connect with any of the professionals that you see here or anybody on our team. We would love to know where you are all calling from, so if you could drop it in the chat where you're zooming from, that would be great. It's my favorite thing to see where everybody is. Ooh, San Jose. We got Canada. I'm from California, born and raised. New Jersey, Georgia, Houston, Texas. Wow, we're all over the map today. That's really cool to see. We are an international organization, like I suggested, so it's always cool to see how many folks. And we do know that the time zones are different for everybody, so we always appreciate y'all coordinating that and joining us for our Zoom sessions. If you're interested in becoming a part of pre-health shadowing, you can definitely register as a volunteer on our website. It is 100% remote to accommodate everybody that we have, so please let us know if you're interested in becoming a member of our team. If you would like to apply to join our leadership team, that's a little bit more of a time commitment, about 5 hours a week. So if you have that time that you'd like to spend with our organizations, we encourage you to check out our website. We have a list of all opportunities and roles that are currently available. And if you see any gaps within PHS that you'd love to fill, please use the link and let us know if there's a role that you would like to apply for or create. If you are a high school student, we have our high school training program, which is a leadership and healthcare opportunity. So, how that would look is our team would reach out to you and provide you with a way to bring PHS to your specific high school, wherever you are. So, we also have an interest form for that on our website. If you're at all interested, again, please let us know. You can always send us an email or check out the website. If you can donate, that would be amazing to help our program stay free and accessible. Our program runs 100% off of donations and the work and time of our volunteers. So if you can donate financially, that would be great. Another way you could donate would definitely be your time, like I just stated, joining the leadership team or volunteering with us. Another great way to donate is to send this QR code or any of our links to your network. We find that there are so many people that want to support, but they don't really know how. So this is a great way to send them over our way so that they can see the great work that we're doing over here. Throughout this session, we will have our chat open, so we would love to see y'all type your questions in the chat. We'll have a formal Q&A towards the end of the session, but just so you don't forget your questions, feel free to note them in there. We'll be taking note and make sure that we get as many of your questions answered as we can. Also, throughout the session, it'd be great to take notes. We will have a post-shadowing assessment that'll be up on our website as soon as this session ends. We'll talk more about that at the end of the session, but it's great to take notes, especially if you hear some new terms or some things that you want to research after the fact. It's great to have those noted down. That way you can ask good questions. If you can, we'd love to see you turn your cameras on. It makes this as close to a true shadowing experience as we can. Just makes it more fun. We'll do some spirit fingers, all the things. So we would love to see you if you could turn your cameras on. We get that some folks aren't able, but if you can, it makes it all the more fun. All right. And with that, I will toss it over to Dr. Ellison. Thank you so much for being here with us.
Well, thanks for having me. Let me go ahead and share the screen. All right, I'm going to minimize your faces and we'll open it back up when we get to Q&A. Well, I'm really excited to be here to talk about clinical neuropsychology. My guess is there's very few of you who have about clinical neuropsych. I just want to throw in the chat. Has anyone ever heard of clinical neuropsych before? Yay, nay, thumbs up, thumbs down. This is a term that I didn't even hear until I was in graduate school already, training to be a clinical psychologist. And then I learned about this specialization called clinical neuropsych. So excited that you all are way ahead of the game at any level you're at, even more than when I first learned about it. So, plan for today is give you a brief introduction of who am I, a little bit about my background and training, and then we're going to talk about what is clinical neuropsychology, and more specifically, what is a neuropsych assessment? And you may have heard that term around tossed around, or maybe you or a family member or friend may have had a clinical neuropsych assessment done. And then the fun part of how would you become a clinical neuropsychologist? So if you're interested in this, what would the education path look like? We'll talk a little bit about what my current job looks like. If we have time, I'm not sure we will. We could talk about kind of normative aging versus not. But likely at that point, we'll transition over to doing Q&A. So a little bit about me. I again didn't know about clinical neuropsych until I was in graduate school. So I did my undergraduate degree at Northwestern University. I was in the School of Education and Social Policy at the time. So I did a double major of human development psychological services and double majored with psychology, and then did a certificate in civic engagement. So at the time, I was really interested in kind of larger systemic issues, as well as individual, working with someone one-on-one, and really was trying to balance both of those. Um, in between undergrad and graduate school, I really wanted to get some real world experience. So I did a fellowship. It was called the Northwestern Public Interest Fellowship, the NUPIP program. It partnered with Princeton, Harvard, and Princeton, U of C, and Northwestern. I'm forgetting the groups that partnered with it, where you're paired with a nonprofit. And then you and your cohort of everyone that was at that nonprofit would meet weekly and get different seminars together. And during that time, I was applying to graduate schools. I didn't know neuropsych existed, so I was actually looking at graduate schools in what was called clinical community psychology. So this is where I would get a degree in clinical psychology, ultimately able to see patients. But I was really interested in also having this dual focus of community psychology, doing research on these larger systemic issues. So the American Psych Association has different divisions, and one of them was Division 27, which really focused on community psych. So I was really only looking at universities that had graduate programs in clinical community psychology, for which DePaul University in Chicago, I was already in Chicago. It was a great clinical community program. They had tuition remission and a really nice stipend, because with a PhD, you typically get paid to do the graduate school, and then your tuition is free. So you don't pay tuition and you get paid to go to graduate school, versus in other medical fields, you pay for graduate school. So that's kind of a nice trade-off with a PhD. And so when you're in a psychology doctoral program in clinical psych, throughout as you're going through, you do 2-day-a-week externships, which are your clinical rotations, where you're at a site for a whole year, and 2 days a week you're at different clinical training opportunities, until you go on to what we call our internship. In medical programs they call residency, and then later postdoctoral fellowship. So while I was at DePaul, I did an externship or practica in neuropsychology, fell in love with it, and kind of transitioned my clinical journey to focus on neuropsychology. So then for my internship, or what med students think about as residency, I only looked at internships that were 50% neuropsych. So I went to the San Diego VA and did my internship in traumatic brain injury, neuropsychology, cognitive rehabilitation, and then half my time was in PTSD in the trauma clinic. And then what's unique in neuropsych is that we do a 2-year postdoctoral fellowship, versus all other clinical psychologists do a 1-year fellowship. So we do a match for internship, did a match for fellowship. And so my fellowship was at the Hines VA, which is just west of the city of Chicago. I wanted to come back home, although San Diego is beautiful. I'm located now at Rosalind Franklin University of Medicine and Science. I am the Associate Director of Clinical Training there, where I help students in the doctoral program with their practica placements, and then engaged in a lot of other national professional service work. So I was the past chair of APA Division 40's Women in Neuropsychology, and then currently serve as our division for neuropsych's representative for American Psych Association. And happy to talk a little bit more about what that looks like among other professional roles. I'm also in private practice. So I see at Michigan Avenue Neuropsychologist, I see patients for neuropsych evaluations, which we'll talk a little bit more about, and for cognitive rehabilitation, which in the Q&A, I'm happy to talk a little bit about what that looks like as well. So what is clinical neuropsych? Neuropsychologists really are determining the extent of any behavioral, personality, or emotional symptoms. We're looking at brain dysfunction and mood and behavior, and really looking at that holistically. So we're our clinical specialty, so specialty within psychology, concerned with cognition, so someone's thinking abilities, their behavioral and emotional problems that may come from either that there's been something that might have happened to the brain, or you might have suspected something that has happened, is really at the core of it what we're looking at. Neuropsych has a really unique history. Back in the day before neuroimaging, really what neuropsychologists' role was to do was to figure out where the lesion was. And so before we had MRIs, before we had CT scans, someone would see a neuropsychologist, they would do a bunch of pen and paper tests and try to figure out, okay, where is the bleed? Where is the tumor? Where is what's going on? Because you can't see inside their brain before that imaging was invented. And so the neuropsychologist job was to look at the patterns that occurred on testing, do an interview and figure out based on their behavioral observations what they saw in testing and what we know about where localization of different disorders are in the brain, and when symptoms happen, where things are likely to occur, to then make a guess of localization. Within American Psych Association, Division 40, which I mentioned, that was developed only in 1980 and then was recognized as a specialty in 1996. But really, most of the early work in neuropsychology focused on traumatic brain injuries. So when there was either a penetrating injury or a blunt force trauma or coup contre coup, where there was, some type of movement that happened. So when someone sustained a brain injury, that's where typically, historically, a neuropsychologist stepped in to figure out where that damage was, the extent of that damage, and to help kind of lay the groundwork for what would happen next in terms of helping this person with their prognosis and where they would go next for treatment. So a lot of neuropsychologists' work initially was around World War I and World War II, with high rates of TBIs. If you're interested in the history of neuropsych and want to nerd out on that, they've got a link for our board exam, Brain ADECN for studying. And so we need to know a little bit about that for our boards. So some information there. So a neuropsych assessment, looking at what is this actual assessment that neuropsychologists do with patients. Really the purpose and goals kind of depend on what the referral question is. So if you have a neurologist or a primary care physician coming and saying, I want to better understand, my patient, and we'll get into what some common referral questions are, but my patient, is this normal aging or is this Alzheimer's disease? Can you help me better understand this? Or this patient had a stroke. I want to track their recovery. Really, the difference in the question is going to change the purpose and goals of the evaluation. But the goal of the neuropsychologist overall is to understand this relationship between brain functioning and behavior, look at patterns of cognitive strengths and weaknesses with your patient, and deviations from normal. So we're looking at both relative strengths and weaknesses. So within that person, what might be something that they're really good at or not so good at, but then also what we would expect based on their age, their gender, their educational history. Where do we expect someone to fall? Because we expect a 6-year-old to function differently on a memory test than an 86-year-old. And so based on what is kind of normal for age or where someone's at in their life stage, is someone performing where we'd expect, or are they much higher or much lower, where that gives us other types of information? And then if something is coming out that it's not normal, not what we would expect, that deviation from normal, what might be the etiology? And we'll talk through in some future slides what are some common etiologies, kind of what are the tree roots? What is the potential cause of those changes in someone's behavior or their brain functioning? And then the fun part of a neuropsychologist is you've got this puzzle of this person. There's been something going on. You're figuring out, is this normal or is it not? If it's not normal, what are all the different kind of pieces of the pie that are contributing to what's causing this? And then you do the recommendations. You're using then your skills as a clinical psychologist to figure out what are all the different things that might be going on in someone's lifestyle, their medical history, that what are the next step for this person to maybe remediate some of the things that might be making the problem worse, might protect their brain for future kind of decline in functioning, or help with mental health and well-being. All those things are going to help someone with ultimately their brain functioning. So you really get this nice big picture of thinking all these ways that help with the patient and then connecting them the resources and moving on. But you're integrating a lot of information from the testing you do, from an interview, from talking to collateral, from your behavioral observations. And we'll talk a little bit more about all that integration that a neuropsychologist does. But why does someone come to a neuropsychologist? These are some common questions why someone might, as an adult patient, see a neuropsychologist. And it's a little different. We'll talk in the next slide of what pediatric focus questions look like. So this might be an adult or over adult saying, hey, I'm just not remembering things as much. I'm forgetting things that are probably pretty important. It's pretty normal as you age to, have the tip of the tongue feeling or to misplace your keys once in a while. But if you're getting lost in familiar places or really having trouble maybe remembering the ingredients and familiar recipes that you've used your whole life, those types of big changes prompt to say, hey, is this normal aging or is there something else going on? Sometimes adults come in and say, hey, I never got evaluated as a child. Can you help me understand, is there ADHD or autism spectrum disorder or some type of neurodevelopmental disorder that's been likely present since childhood that just might have gone undiagnosed? Sometimes adults might come in and say, hey, I need a baseline. I want to see what's normal for me now before I get older, or I want to track progression. I had a stroke, I had a head injury. I'm 6 months out from recovery. I want to basically see where I'm at now. Now I'm a year out, kind of see where things have improved. There's also a whole legal forensic side where there might be for a lawsuit. Maybe someone slipped and fell or got hurt on the job and trying to understand where things are at in terms of their cognition so that they can litigate or maybe sue the workplace where that happened and document the extent of those injuries. There are federal aviation evaluations of seeing if someone's maybe cognitively intact and able to still fly planes. There's been a lot of NFL cases where there's litigation for having financial compensation due to traumatic brain injury. So this could be completely, as a clinical neuropsychologist, you can work in a clinical context and you can work all the way through in a forensic context. For pediatric patients, some of those referral questions look similar and some of them look a little different. This might be a kiddo who's not reaching developmental milestones on time and trying to figure out maybe they were and maybe there was a regression. Is there something going on? Can you help us get to a diagnosis and understand where they're at and understand some recommendations for what they should be doing in school or accommodations for a 504 plan or an IEP at school. So that might be assessing for neurodevelopmental disorders like autism spectrum disorder, ADHD. Similarly, in adult cases, it might be tracking progression after an injury or an event. Sometimes it's just documenting the need for accommodation. Someone has had difficulties and now needs kind of the paper trail for accommodations, maybe for extended time on testing for the ACT or the SAT, or now they're going into graduate school and they need documentation as they get older. So really these questions can kind of span seeing where someone's at in the moment to there's been a big change to figuring out, I'm not sure what's going on. Can you help me figure out the puzzle pieces of what might be going on with this individual and give me those then recommendations and next steps of what happens next? So more specifically, I had a concussion and I'm having trouble kind of remembering things at work. Are the things that I'm experiencing now, is this due to the TBI? Is this due to something else? Can you help me tease this apart? A lot of older adults are concerned about Alzheimer's disease and wanting to know, is this normal aging? Or is this Alzheimer's disease? Or is it something else? There are a lot of different things that can cause non-normative decline as we age. Some of those are progressive and some are not. And so understanding if it's Alzheimer's disease versus frontal temporal dementia versus Lewy body dementia, all of those have different implications of what happens next and what the prognosis looks like. I'd like, my child has X, Y, and Z known diagnosis, and I want to better understand where they're at right now, get a baseline, start a paper trail for school, and get updated accommodations for school. These are all kind of different common questions. Neuropsychologists also sometimes work in medical contexts where they might do assessments for surgical candidacy, for epilepsy, where they might be cutting kind of across the corpus callosum down the middle. Or it might be assessing to see candidacy for a spinal cord stimulator, or in Parkinson's disease, candidacy for a deep brain, a DBS stimulator. Sometimes there might be WADA testing where someone is awake and you're trying to lateralize where language is and lateralize where different things are in the brain. So you have someone fully awake, you numb parts of the brain, and then you're doing, while the brain is open, you're doing testing in the operating room. Now, a lot of hospitals are moving more to non-invasive fMRI language mapping, but a lot of hospitals still use this WADA testing as well. And historically, that's been where a neuropsychologist has been involved in this medical context. Also, sometimes in a medical inpatient setting, you're tracking cognition as an illness progresses, or trying to understand, is there been an acute incident? Is this delirium where we'd expect, due to maybe the patient has a severe UTI or post-surgery, we expect things to rapidly get better? Or there might be something else going on, like an encephalopathy or a toxic metabolic condition, something else acutely where we want to see where their cognition is at and track them during that inpatient stay over time. A lot of times in this medical context, neuropsychologists are contributing to differential diagnosis and trying to tease apart, is this depression or is this dementia? What might be going on? Early detection of different etiologies of cognitive decline that may have a medical basis that need intervention. And again, determine how bad things are, track severity, and then track progression across time. Trying to figure out if something's going on, is it diffuse across the whole brain? Is it local? Is it lateralized where it's one side or the other? We do have imaging that can help, but then also information from neuropsych evaluations can help us kind of further gather that information too. Is something static, or is it progressive where it might be getting worse over time? And then also, is what's going on cortical or is it subcortical? Is it in the gray matter or is it in the white, gray matter or white matter, to help us better understand what's going on? A lot of times in a hospital setting, we also might come into questions about capacity and competency. So this comes up especially when individuals go against medical advice. Usually if someone's going along with medical advice, this doesn't come up. But if there's a really big decision and someone is saying, I don't want that surgery, or I don't want that transfusion, something where the medical team has said, yes, you need this for your health or for to survive, and someone's saying no, in some cases, then there becomes a question, is there some type of concern where someone isn't able to cognitively make that decision? So a neuropsychologist will come work with the team to figure out, is there functional capacity, decisional capacity to make a decision, or functional capacity? So decisional capacity is kind of legal in the moment. Can you can you make that decision to say no to the surgery? Functional capacity may be something like you've been an acute medical inpatient and there's concerns about your cognitive functioning. Are you safe to go home? Do they feel like now after this event and this decline in cognition or what they're seeing in the medical inpatient unit due to where your cognitive abilities, the medical team, the surgeon, or the neurologist is kind of observing, having the neuropsychologist come in to see, is there a true concern in terms of where someone's at cognitively, where they might be safe to go home or may not. And really what a neuropsychologist is looking for in all of this is, does someone have the ability to make a decision, and not whether it's a good decision or not, because we all have the right to make poor decisions. We all have the right to go eat a whole pizza in one night, but that doesn't mean you can't make a good decision. And so the neuropsychologist is really looking, can the patient communicate their preference? Do they understand what's going on? Can they appreciate kind of forest from the trees, how this decision might be different from them versus a friend versus a family member? And are they able to show their rationale in their thinking, and kind of formulate their decision? And sometimes this can get really tricky if people are paralyzed or have other kind of physical limitations and barriers to communication. And so this is kind of some unique considerations that come up in a medical context where a neuropsychologist gets pulled in. But neuropsychologists work across all settings. So they work in hospitals and veteran health administrations and university medical centers and rehab institutes, private practices. I work in private practice, and then I'm a faculty in academia. Um, Sometimes neuropsychologists, in addition to doing these more comprehensive evaluations, because we're trained also as a clinical psychologist, do other types of translatable skills. Sometimes there's cognitive rehabilitation, which looks a little bit sometimes like executive functioning coaching, which you might have heard that term before. So this might be in the context of someone with ADHD, or maybe some psychiatric diagnoses where there's significant executive dysfunction, like in individuals with schizophrenia, or post-stroke, or post-traumatic brain injury, helping with tips and tools for learning and for memory, remembering people's names, calendar planning. Some neuropsychologists do more typical therapy and intervention. Some do things like biofeedback, and some do more talks and psychoeducational workshops as well, since there's kind of this expertise in this brain body interventions, and integration, and what to do to protect your brain. And so that's something that I used to do a lot of, is giving, caring for the aging brain talks, and information about different things that can happen to the brain and how we protect our brain. So I mentioned the word etiologies a few times, causes of cognitive impairment. And so as a neuropsychologist, we're figuring out if something is looking like it's not normal, what are those puzzle pieces that might be contributing to what's going on? And so we're looking at, it could be something related to a traumatic brain injury, which might be, as kind of I mentioned earlier, something that is maybe something that penetrated, a blunt force. It can also look like something like anoxia, where there's a loss of oxygen to the brain. There could be tumor or cancer, or sometimes the treatments that go along with cancer. Vascular, so cerebral and cardiovascular related issues, diabetes, high cholesterol, hypertension. All these same blood vessels go up to our brain. And so a lot of different vascular related issues can cause brain related changes as well. Infectious diseases, some cross the that is a tongue twister, the blood-brain barrier. And then I mentioned with dementia, is typically when we're performing significantly lower than expected for age, and we're also having significant functional impairment. There are different types of dementia, and some of those are what's called neurodegenerative, which just means they're going to get worse progressively over time. And there's a lot of different types of those that all look very different. There might be a movement disorder or a seizure disorder or medications from seizure meds, autoimmune or demyelinating conditions. So psychiatric concerns, as I mentioned, sometimes it's figuring out, is it depression or is it dementia? In older adults, those can look very similar. PTSD in itself is a disorder of memory. It impacts and takes a lot of resources of the brain and can impact our attention, our memory. But a lot of other mental health concerns can also impact our ability to encode information or our attention, our learning, our memory. Things like hydrocephalus, other endocrine related issues, or things from childhood, neurodevelopmental disorders, continue as people grow into adulthood. So this is not an all-inclusive list, but we're kind of looking at all these different factors to see what might be going on. And as a neuropsychologist, we have a sharp focus on things that we can impact and things that we can't. So I can't really do anything to change if someone's had a brain injury or a stroke. We're really looking at just recovery afterwards. Um, but there's a lot of things that cause changes in cognitive functioning that are treatable. And that's where it can get almost fun as a neuropsychologist to think about how can I help this person? What things might go in my recommendations that might be able to improve this patient's life or daily functioning or prevent future decline. And so we're really looking, to figure out what's going on and if there's any treatable causes that are pieces of the puzzle. What are those next steps? How do I connect this person to resources or give the resources to their other providers to set this person up to succeed in the future? So in terms of what a neuropsych evaluation looks like, if you're in a larger medical center, you're or wherever it is, you're getting a referral, which is what the question is, and we talked about what some of those referral questions are. Um, we are looking at someone's chart and trying to look through all the medical information thus far. And even just between the referral or even just without the chart review, which is the referral itself, we're already developing some initial hypotheses of what might be going on, what's higher in our differential list, our list of possible etiologies of things that could be going on, and what's lower. And as we're moving through this process, things are moving higher in our differential lists and things are moving lower, kind of like the show house where he has the whiteboard and writing things on and moving things up higher, lower. It's the same thing that a neuropsychologist is doing. As more data points are coming in, you're crossing things up, you're moving things higher, you're moving things lower. For example, if I have a 6-year-old coming in, I'm probably not thinking Alzheimer's disease. There's going to be different things that are higher or my lower, just even based on someone's age and the referral question. So I'm going to, that's going to inform what tests I'm considering giving. And those tests may also change as I go through the testing day. Neuropsychologists also do a comprehensive clinical interview. I typically meet for about 75 to 90 minutes with the patient prior to testing. Some people do it after testing to gather a lot of information about what's going on now, and then go through a full history with them of their medical history, their psychiatric history, their educational history. I'm also a lot of times calling what's called collateral. So if it's a child, I'm talking to their parents. If it's a young adult and it's a question about a neurodevelopmental disorder, something that would have likely started in childhood, I'm also probably trying to talk to parents, caregiver, a grandparent. If it's an adult, can I talk to an adult child? Can I talk to a spouse? I'm getting all those data points because especially for some disorders in older adulthood, a person might not have good insight where they might say, yeah, everything's fine. My memory is great. And then you talk to the adult daughter and they say, yeah, everything's great, but they got lost on the way home. I went in the trunk in their car and there were 3 different bags of McDonald's that they purchased and forgot that they went in there. They had groceries in the back seat from a week ago. They forgot, which is very different than the information that you got from the patient. So you're getting that collateral information as well. All of this might modify my test selection. And one thing to note when you're doing the clinical interview, you're trained as a psychologist. So even when I'm doing the interview, I'm actually already starting to do feedback for what might be coming in that feedback session during that clinical interview. So if I see that the patient, their sleep is all messed up, I might already start to do some motivational interviewing to ask their thoughts about their sleep or start to suggest some recommendations or have you thought about doing X, Y, and Z? Have you tried this? So the idea is that when I give the feedback at the end, most of that feedback hopefully isn't new and it's stuff that we've already started to talk about. And so I'm already starting to do some actual intervention, almost the pre-feedback session even during that clinical interview, but I'm also flagging things that, again, might be relevant for recommendations or in that feedback session later. You're building a lot of rapport and relationship building with the patient so that you can have the best outcomes in testing. The formal testing, we'll talk about what that looks like, but that's looking at a number of different activities across cognitive domains. So I might be assessing their attention, their memory, their executive functioning, and we'll go into what those domains look like. There might be some more looking at functional capacity where I'm actually having someone write a check or make change using standardized tests. So these tests are all objective and standardized. What that means is that either myself or a technician is administering them in the same way to every single patient so that I know when someone performs in a certain way on the test that it's not about who administered it or how it was administered, that there's some objective scores that are coming out of that. And as a clinical neuropsychologist, I have to be well aware of the limitations and strengths of each test and the unique cultural background of my patient to know if this test is even appropriate to give someone in the first place, or if the data I'm getting from this is helpful or not. Because if you're putting, bad data in is bad data out. So I need to be able to understand the tests and the nuances of them to know what those tests mean and if that data is going to be usable. Then all those tests are going to get scored up. And this is where you're integrating all that information. So I'm going to integrate from my behavioral observations of the patient, the interview with the patient, the collateral interview, the test results themselves. They might have filled out also the patient some self-report questionnaires, pull that all together, and I'm going to put together a big report that has their whole background. It's going to have answering the referral question of is what's going on normal or is it not? And if it's not normal, what are the etiologies of cognitive decline? What might have been contributing and what are the recommendations and next step? And then typically a neuropsychologist gives feedback to the patient or family and goes over all this information. The actual evaluation itself can be anywhere from 45 minutes in an inpatient setting to 8 hours. Maybe it's broken into 2 or 3 days, especially if you have a forensic case or a pediatric patient that maybe you can only do 2 hours at a time. The length really depends on the referral question, the frustration tolerance of the patient. If a patient has very severe dementia, they're probably not going to tolerate more than 45 minutes of testing. But if you have a young adult and you're doing an ADHD evaluation, you're going to have longer tests looking at sustained attention and probably more tests that need to document for accommodations for school. If you're in an inpatient or outpatient setting, that might change the length. Inpatient evaluations are typically very short. And again, if there's other limitations, maybe the patient has chronic pain or other medical considerations where they really can't do a longer battery. And so you're trying to get the most bang for your buck in a short amount of time with enough redundancy in testing to have that convergent validity. Because someone can maybe do poor and one test here and there, and you really want to have that as well, but not making something overly and unnecessarily burdensome on the patient. Again, everything is objectively scored using normative samples. So if someone gets a raw score of something on a test, you're converting it to what's normal for that person's age or gender. And everything is delivered in this standardized format, and you're integrating quantitative and qualitative interpretation across different tests. Again, as we talked about the purpose of these evaluations, you're determining kind of this overall relative pattern of cognitive strengths and weaknesses, determining the extent of any behavioral, personal, or emotional difficulties. Are there any relative weaknesses or things that are normatively below expectations? And then think about what happens next, that treatment planning, the recommendations, and then helping with differential diagnosis. Some things that we really need to consider as a neuropsychologist is making sure not to over-pathologize. Think about age. What's normal for a 96-year-old? And for some of these tests, looking at the normative sample of how much data do we have for people who have taken this test who are 96? You need to understand the impact of culture, someone's primary versus secondary language, testing what it means if you're testing someone in their non-native language. Understand if someone has sensory or other physical limitations. Maybe they have hearing difficulties or vision difficulties that are interfering with testing. Maybe someone wasn't born in the US, where in the US we have a very in Western culture, everything is speeded and you're taught from when you're young to move quickly through tests. And that's part of our educational culture. But in different places around the world, speed is not taught and graded and prioritized, which is important if then our tests in these neuropsych assessments have a speeded component and knowing that there might be cultural considerations from that. We also need to think about what's called ceiling and floor effects. Does the test have enough range for someone who's really, really bright to see how high they can go? And for someone who's really, really struggling to see the extent of those difficulties? Because different tests might cap you where you can't look at giftedness, and different tests might kind of bottom out where you can't see the extent and really where those intellectual difficulties that are, or in the middle, trying to understand does someone have MCI or mild neurocognitive disorder versus dementia and really being more sensitive to that middle ground. Some of these tests do better at that as well. We also need to consider, things like processing speed and attention can impact other higher level functions like executive functionings or memory. So really looking at what does this test measure and what other domains might be impacting what I think it's measuring, and the limits of that. And then what we call ecological validity. So there's no driving test. I'm not putting someone behind a wheel and seeing, if they can drive or not. You're in a distraction-free environment. And so I have tests that are serving for a proxy for different abilities. But our test of executive functioning, maybe of set switching or inhibition, is not a perfect one-to-one of how someone's executive functioning is day to day. And so, understanding how much these tests do or do not translate into real world skills is something that's pretty important. So this is a larger list of the different types of domains that are included in a typical test battery. Things from pre-morbid abilities, I'm thinking about before a stroke or before an event were to happen, kind of general IQ, academic functioning, and then all these other domains. And one thing we also really look at is their effort or motivation. So there are tests either embedded or added to this testing battery to understand if my patient is putting forth a full and consistent effort. Because if there are things that might be unintentionally interfering, or sometimes in a forensic setting, intentionally interfering with someone's ability to perform their best on testing, bad data in is bad data out, and I need to understand it if I can trust my data. So I'm going to go really quickly through test domains. These slides are available, and so they can be referenced. So again, we've got the pre-morbid ability. A lot of times we're using a word reading test because our language skills, unless there's a stroke in that area, are most protected. We've got attention, concentration, processing speed. We're looking at basic attention, grabbing your attention versus sustained attention, auditory attention versus visual attention, processing speed, how fast you can think, how fast maybe you can think and write with your hand. And this can fluctuate throughout an evaluation. With learning and memory, we're looking at verbal learning versus nonverbal. Can someone remember a list of unstructured information versus something in context in a story? And then we're looking at those learning and memory patterns, and working memory is that chalkboard in your head. Your ability to manipulate things is very different than learning and memory, and is actually a little bit more of an executive functioning. There are different patterns in someone's encoding, learning, and memory, and those patterns can help us, again, understand etiology. So this is just one example of how Alzheimer's disease, things break down different in the learning and memory process than, say, someone who has vascular-related dementia. Executive functioning is a huge and complex domain, integrated across many other domains. So this might be set switching, inhibition, problem solving, planning. And then we talked a little bit about effort and motivation. We mentioned briefly some of these other areas to assess. Some might be visual spatial or visual perception, someone's fine motor skills, mood, functional abilities, social skills. All of these, depending on the referral question, might be different areas that neuropsychologists assess. Or really, this is what we're talking about when we're talking about what's normal and what's not. Is someone falling in this average part of the bell curve? So if we have this bell curve here, most people are falling in this middle part between 25 and 75th percentile. As a neuropsychologist, I'm interested in someone's falling in the tail. So if I put you in a room with 99 other people, are you performing better than most people in the room, or are most people in the room performing better than you? If someone's in the average range, sometimes it's helpful for me to understand their relative strengths and weaknesses. You know, if someone's, even if everything is looking normal and average, if there's these big gaps, that also gives me some different information as well. We talked a little bit about the limitations of neuropsychology tests, so I'm going to move because we're short on time to how do you become a neuropsychologist? I mentioned this a little bit briefly in the beginning when I was talking about my trajectory. But typically, first we're looking at, an undergraduate degree, where in that or in your post undergrad experience, you really, because you're getting typically a PhD, although you could get a PsyD as well, you're typically getting some strong research experience. So in that undergraduate time, you're maybe volunteering in a research lab, trying to attend a conference, maybe work with a lab, get on a poster. Um, Typically, many people are majoring in psychology or neuroscience or related fields, and maybe taking some classes after their undergrad if they need to bolster some of those areas. Then typically, it's applying to doctoral programs in clinical psychology. Your training is as a clinical psychologist. You can apply to PhD or PsyD programs, and I'm happy in the Q&A to talk about the difference between those two. There's pros and cons. And during your doctoral program, you're doing those 2 to 3 day a week externships for 4 to 5 years during your doctoral training. Um, Typically, if you're in a PhD program, you're doing research along that same time. So you have a master's thesis, you have a dissertation, you have a clinical comprehensive exam, and you're doing these 2 to 3 day a week unpaid training opportunities at one site throughout an entire year. At the end of your doctorate, you are applying in a match for your residency, your clinical internship. For clinical neuropsych, some of your externships would have been in clinical neuropsych. And then for your internship, you're applying to residencies or internships that have at least 50% neuropsych and trying to match at one of those sites. Now you're on internship in your residency, and in that year, you're reapplying now for our fellowship. And you have a 2 year postdoctoral fellowship in clinical neuropsych. That's when you're also taking the licensure exam. It's the same licensure exam that the EPPP that clinical psychologists take, because it's a license in clinical psychology, but you specialize in clinical neuropsych. So you get licensed as a clinical psychologist, but you have a 2 year postdoctoral fellowship in clinical neuropsych. And around that time after you finish your fellowship is when we take our board exam. So in clinical neuropsych, then you take your board exam after your 2 year fellowship. So clinical neuropsychology is considered a specialty at the postdoctoral level, that you're doing again at that 2 year fellowship with some experiences that you've done throughout your doctoral program. But most people are not having experience in clinical neuropsych in the undergrad or post-bac. It's kind of more these general research, and some maybe some volunteering with some patient focus experience. I have some resources in here for people who are interested in this. Resources about our board certification. We have the Minnesota Conference Guidelines came out this year. This has education standards and guidelines at all different levels for the field of clinical neuropsych. And then there are a ton of professional groups in clinical neuropsych. If you're interested in getting involved, learning more, there's a ton of national and international groups, as well as some other really great resources for different identity-based groups in neuropsychology you can join. Most people join at the doctoral level for these, and they have great student rates at the doctoral level. But if you're an undergraduate or in your undergrad or you're in high school, these are some really great resources for kind of learning more about the field and maybe applying to graduate programs later. So no neuropsychology has recorded webinars and didactics related to clinical issues, professional issues. NAV Neuropsych is a podcast, and New to Neuropsych has a ton of resources for people looking to apply to graduate programs, so to clinical psych programs with the ultimate goal of becoming a neuropsychologist. So I'd say these are the ones before you get into graduate school to really focus your time and attention. And No Neuropsych is fun because it's a ton of YouTube webinars, again, all about either clinical issues, professional issues, etiologies of different disorders that cause cognitive impairment. So it's pretty cool. The NAV Neuro, I'd say the one really cool thing about it is they do a lot of what's called fact findings, which is part of our board exam, where you are gathering information about a case. And so you'll hear someone on the podcast doing that, talking through their thought processes in terms of that differential list up or down as they gather more information, and then talking about, is this normal, is this not, and what are the etiologies of cognitive impairment and the possible diagnosis. I'm happy in the Q&A to talk a little bit more about what my job looks like. I know we're running short on time now, so I may kind of leave it there, but I'm happy to talk about that if people are interested in our Q&A portion.
Thank you so much, Dr. Ellison. That was great. Appreciate the resources at the end there too. If anyone needs those links again, feel free to send us an email and we'll make sure to get that information over to you. We do have a bunch of questions in the chat, so
Okay.
we can jump in. I see a question here from Juan that says, how do you differentiate core social communication deficits in autism from broader cognitive impairments identified on neuropsychological testing?
Yeah, that's a great question. So I think that's where it's this comprehensive exam. So in autism, I guess it also depends, is this a kiddo coming in? Is this an adult coming in? But typically it's this multi-pronged approach. So in an autism evaluation, one of the gold standard assessments is the ADOS, which has different levels depending on where someone's functional impairment and abilities are. And in these structured standardized social situations, which you can objectively score. So you have some of those objective scoring. You have parent report, teacher report, self-report, depending on the age, to gather that information about those different social deficits. And we have that cognitive testing too, where we can see where someone's executive functioning are, where that learning, where the memory is, and those different pieces. The other piece of it with autism spectrum disorders, we're not just looking at social deficits. So in the DSM-5 TR, there are kind of these two different buckets where we're looking at both these atypical social interactions, and we're looking at restricted and repetitive behaviors, as well as kind of the underlying with any diagnosis, the impairments in functioning. And so, for someone that maybe just has some social deficits, but no restricted and repetitive behaviors, then that might not be autism spectrum disorder. A lot of symptoms for ADHD and autism spectrum disorder are what we call they're very non-specific. So when we think about a Venn diagram, there are lots of other things that can cause social deficits. As you mentioned, there might be cognitive deficits impacting that. There's lots of other things that can cause, for the ADHD, attention deficits or executive functioning deficits. And so that's where getting a neuropsych evaluation actually teases those apart, because you have all this information where then you can paint this whole picture by pulling in all that data. Great
Uh,
question.
I heard you just mention the DSM-5, and I've seen it one
Yeah.
time and it looked so thick.
Oh,
So I'm
I've got it right
wondering,
here. It's so beautiful. It's a beautiful color this year. So this is the DSM-5 TR. They also make the desk reference, but you can also find PDFs of it online. So a lot of clinicians and faculty have a PDF version, kind of easy to reference. Um, but yeah, that is in the US. We use the DSM-5 TR for the diagnosis of psychiatric or neuropsychiatric disorders. We use the ICD-10 for billing typically, and the ICD-10 also has all of the medical related disorders. So the DSM-5 TR It's by American Psychiatric Association, is exclusively related to psychiatric and neuropsychiatric diagnoses, for which the ICD-10 also includes those. But in the US, that's how it's done, is that the diagnostic categories are done based on the DSM-5 TR. And then when you bill, you use the ICD-10 code. So it's a little bit funky. That's the way it's been done for a long time. Yeah.
Thank you for
But yeah.
showing that to us. It is a
Yeah.
pretty color, but looks a little
Yeah.
daunting, the thickness. Our next question says, how do you distinguish deficits in social cognition from executive dysfunction when both contribute to functional impairment?
Yeah, and I think that gets at kind of that same question as before, is when we're doing a test battery, we're looking for convergent validity. So, I'm going to have multiple ways of looking at different aspects of social cognition. I'm going to have multiple ways I'm looking at expressive language, receptive language, those kind of cognitive aspects of language. And then I'm going to look at multiple ways of, assessing executive functioning. And so all of those pieces are assessed concurrently and separately. Some of those pieces intersect, and you're really looking at all of those pieces together to understand where someone's at, because there are executive functioning tests that don't have a social component. And there are social tests that do. And so, again, you're looking at convergent validity and tests. As we mentioned, some of the tests cover multiple domains and some cover kind of more independent domains. And so, as a neuropsychologist, I need to be acutely aware of when different cognitive domains or deficits in social functioning may impact someone's performance on a test or their ability to understand test directions. And that's why it takes a very long time and many years of training, because you have to understand the strengths and limits of all the data coming in from these tests and all the data possibly coming out. So vague answer, but yeah, that's why it's a long battery, and you're doing an interview, collateral interview, you're having self-report data, and then you're doing a ton of these objective tests across different domains, including objective tests to look at social functioning. But yeah, executive functioning tests are there some of my favorites.
When you mentioned cognitive rehabilitation therapy, you mentioned that you could expand more on what that
Yeah.
is. Yeah, can you share that with us?
Yeah, I love cog rehab. I think it's a really fun kind of in between where it's not quite therapy, but it's really focused on tips and tools and strategies for helping someone accommodate their whatever the cognitive deficits might be. And those might be neurodevelopmental, they might be lifelong difficulties, or they might be acquired maybe in adulthood. As I mentioned, there are different psychiatric disorders like schizophrenia that tend to have difficulties with executive functioning due to structural and functional changes in the brain. ADHD, as we know, and different neurodevelopmental disorders also can have those same difficulties. But we can also have acquired events like after a stroke or a traumatic brain injury or some types of acute infections that cross that blood-brain barrier, where maybe the way that someone, remembered to do things or paid attention to things is not, it doesn't work for them anymore. They need different tips and tools for helping with that paying attention, for that encoding, for that learning, for that memory. So I will work with patients on setting up calendar planning. So how do you set up organized structures for and routines for checking your calendar daily, weekly, making sure things go in the calendar, to how do you remember names in conversation, to things around, functionally, if you're in a movie theater and you go leave your seat, how do you remember what movie you were watching to come back to that? How do you remember where your car is parked in a parking lot? How do you remember to bring things that you need to bring outside of a house? Or, it might be teaching different problem solving techniques. If there's a binary solution versus there might be multiple solutions, and practicing cognitive flexibility of even teaching, all right, you got your first day of class. Let's kind of brainstorm together and how do we think flexibly and set shift of all the different types of things I might need for that first day. So really you're helping patients achieve a higher level of daily functioning towards their life goals and thinking holistically about whatever those goals are and helping teach different tips, tools to improve their daily functioning.
Hmm.
So it can look like where it's 3 sessions with someone, or it might be 8 sessions. You could do it in a group, you could do it individually. A lot of people use manualized interventions and modify them. And so there's a few manualized interventions that I use. I also do a lot of research on cultural modifications for manualized interventions for cog rehab. And so that's something that for research I'm passionate about and is really fun of how do we tailor some of these interventions for different groups or for different specific clinical disorders. But yeah, a lot of people will do it based on some type of manualized intervention and then modify it for that patient's specific concerns.
Hmm. Brianna, I see you have your hand up. Feel free to ask your question.
Hello, can you hear me?
Yep.
Yes.
My questions are, in this profession, do you see or treat patients with PNES, psychogenic non-epileptic seizure disorder, or any patients with convulsive syncope in regards to the vasovagal syncope and dysautonomia? And then I said I was misdiagnosed with PNES by several neurologists until I had a tilt table test done that showed POTS and neurocardiogenic syncope. I'm interested in a profession that works with patients with these disabilities, but I'm also very interested in all things neurology. The current plan is to pursue becoming an autonomic neurologist. So I'm really
Yeah. And
interested in psychology, but I'm also really interested in neurology as well. I have the fainting, but then I have convulsions during it. So not knowing anything at the time, I was going to neurologist thinking it was epilepsy or something. So they saw the convulsions and thought, oh, like non-epileptic seizure disorder, but it ended up not being right. But during that time, I did a lot of research on seizures and just really found it fascinating. So I was wondering if you ever see any patients with any of these things.
yeah, that's a great question, and thank you for sharing. I actually have POTS too. But yes, the short answer is yes. That many neuropsychologists, there's a many neuropsychologists who specialize in PNES. We actually I have a book that came out, and I'm happy to send an email for anyone who wants a copy of this book. I have an electronic copy you can reach out. This is Neuropsychology of Women, Clinical Research, Considerations for Clinical Care and Research. And so there's a chapter on, it has information on unique considerations for women with the in terms of diagnosing and cognitive profiles and what we know for women for the different disorders that you had talked about. There's a kind of a chapter devoted to that. But yeah, there's a lot of neuropsychologists that work in this space, and a lot of people who have been interested in neurology and psychology somehow find their way to neuropsychology because it is a nice in between where you get to work with these different disorders and have expertise in them, especially depending on what clinic you're working in. Uh, and kind of straddle that line between those two fields.
Thank you for sharing that with us, Brianna, and for asking your question. Appreciate it. The next question in the chat that we have is, how do you distinguish primary attentional deficits from broader executive dysfunction during neuropsychological evaluation?
Yeah. And I think this gets to the same questions that other people are asking. And how do you distinguish when there's two overlapping pieces? Um, I part of it, yeah, I think part of it is like the makeup of your battery too, of making sure that you're assessing different types of attention. And understanding which tests have a larger executive component versus which ones do not, which executive tasks have a larger attentional component and which ones do not. Um, thinking about speeded tests are going to have a lot more of executive demand and attentional demand than unspeeded tests. And so part of it is really understanding this overlap in the different domains and how much different domains are implicated in different tests to tease that apart. And at some point also, with these types of questions, it's a little arbitrary, and it almost doesn't matter unless you're looking at, does that question answer a difference in etiology? Because sometimes it's, whether it's 40% attention or 60% executive functioning, doesn't matter. Both are coming from this known etiology that we've identified. And I'm going to treat it the same way, whether one's at 40% and one's at 60% of that puzzle piece, where it's more important really to understand at what level are the attentional deficits relative versus normative. So is it a strength and weakness for that person, or is it a strength or weakness compared to where they should be at, kind of in terms of normative expectations? And is one of them better maybe to tackle first, in terms of, we need to really focus on this. So like if someone is coming in, for I think of a good example. I guess the more common thing that comes in is that people a lot of times will come in and say, I have a memory problem, where really it's not a memory problem. You're really finding out that it's an encoding or an intentional problem. So sometimes teasing that apart a little bit can really help you see where to intervene and where those strategies are going to be most helpful. Am I trying to increase someone's funnel in terms of their encoding? Or is it kind of a learning and organizational piece, or is it an intentional piece with learning and teasing that apart? But most of the time, yeah, most of the time it may not be as important at the detailed level to understand exactly how much of each of these, because they're so intertwined, unless it's impacting etiology and understanding why what's going on is what's going on, or what to do next.
I'm wondering, kind of in this, I don't know if I would call it a new age, but there's so many accessible resources. Do you ever have people that come in, like, I Googled this extensively, I know exactly what it is,
Uh,
and I just need you to tell me that I,
yep.
what I know I have.
Yep. So, oh goodness, it's like the bane of my existence right now, because my background is in traumatic brain injury and different types of dementia. But all I'm seeing right now are adults and young adults coming in who want to rule out neurodevelopmental ADHD and neurodevelopmental autism spectrum disorder, with usually some type of complex psychiatric history and maybe a little bit of OCD. And that is kind of the most standard referral that I'm seeing, and most private practices are seeing post-COVID. So it's a lot of people trying to do TikTok armchair psychology, and looking and saying, I am reading this book, I'm checking off all these symptoms. And part of that is, I think, is for better, for better or for worse, I think is a really good thing that some of these neurodevelopmental disorders and mental health disorders have become destigmatized. And so there's a lot more open discussion and a lot more comfort in that self-identification. And I think what's really hard is post-COVID, because the stigma has gone, it becomes a lot easier uh, to self-attribute to kind of almost like this external thing. Like, this is I'm in my ADHD bucket or my autism bucket. And that externalization and putting that label on can really detract from, most of the time, what's really going on is that maybe there's some dysregulated sleep. Maybe there's some anxiety and depression that's been untreated. Maybe there's something else going on, or now I'm in trying to do X, Y, and Z, and this is really hard, and I want some extra thing to tell me what's going on. Or, I'm feeling really uncomfortable in these social situations now. But yeah, that's because you had multiple years of really, awkward, traumatic social experiences with COVID, or maybe missed out on some really key social learning. And so, yeah, so there's a lot of people coming in who kind of are self-diagnosing, but I think it doesn't matter, because the valuation is such where it is comprehensive, and I'm going to hold that in my hand of what someone's telling me and give it weight, because someone knows their own lived experience. But I'm also going to look at, what am I seeing? What am I seeing on objective testing? What am I seeing on behavioral observations? What is collateral telling me? Because if someone's coming in telling me, I have ADHD, and then I go and talk to mom and grandma and dad, and everyone's like, Yeah, they packed their own lunch every day. They never forgot a thing at school back and forth. They always had the most organized backpack, and there was never concern with a teacher, elementary school through junior high until I got to high school. Usually that's telling me that there's something else based on the chronicity of that, and the timeline gives me other data points too. So long answer is yes. It's very, very common right now, especially in private practice setting where a lot of people are in this post-COVID period. There's a lot of popularization of exploring neurodevelopmental disorders, and most people coming into clinic are not, or that's not an appropriate diagnosis, and they do not receive that diagnosis. Or maybe it was told by a PCP or someone else that did a screener based on this person's information. It is true, but many times then when you go and do the full evaluation, it's not.
Um, Somebody messaged me and asked, have you had to make any adjustments since COVID for the way that you diagnose specifically young children
Whew.
that were born or ages 0 to 5 during that time?
Yeah, so I don't see pediatric cases anymore. I only see adult cases. But I actually gave a talk to my students, their doctoral students in the clinical neuropsych program or track at Rosalind Franklin about this and about how the disruptions to COVID have caused some pretty complicated diagnostic considerations. Because now, when you think about even learning disabilities, if someone's coming in and on achievement testing, if they're performing below grade level, is that because they are having difficulties with some kind of cognitive area where they're trying difficulty kind of acquiring or obtaining that information? Or were there gaps in their education? Were there social skills related gaps where most students, depending on in what part of COVID they were lockdown was, they might be 1 to 2 grades socially behind. They might be 1 to 2 grades academically behind. And it's really important as a neuropsychologist when you get that clinical interview locked different across the country. And were you in a school district where it was locked down, but for all intents and purposes, everyone was back at school the next day? Were you somewhere where it was all remote, but most kiddos didn't have private tutors and perfect internet access? Were you in lockdown when you were in first grade, where Zoom learning isn't conducive to learning, where even if you were home with great internet access, you weren't really learning that much anyways? And so those are all huge considerations that have impact cognitive development, acquiring executive functioning skills that students may be delayed in. And so it really depends on where someone was at. And part of that clinical interview is really understanding what that looked like and what else was going on at the time, and conceptualizing that. There's also the piece when in understanding the tests, any tests that might have come out during COVID, even understanding those sample sizes of what is the normative data set. Were those normative groups now groups that were after COVID? Because or was that data collected pre-COVID? Was that data collected where people were in mass? And as a neuropsychologist, again, it's a research degree at the base. As a clinical psychologist, I have to understand the normative sample behind what the tests are based on. And so COVID has a huge impact on that as well. And can I interpret this? Does a 5 on this test that translate to this kind of with the statistical normalization, is that what I actually think it means based on the normative sample it's using? Does this match my patient? Or because my patient, experienced COVID and is typically 3 grades behind now, does this really match up where I can really understand, like, this data, does it make sense? And so that's a big part of is kind of the field is, does my patient match the normative data of the test? And COVID has put a really funky wrench in that in general, and why glad right now I see adults and not peds. Although 5 or 10 years, like, those kids grow up and it will still have to be a consideration. But yeah, big issue.
Next question I see is, how do seizure-related disruptions in medical temporal structures affect encoding versus consolidation of memory?
Oh, it's a great question. I think a few things are like, so most seizures are temporal lobe seizures. So kind of first and foremost, with seizures, we have a few different considerations. So we have, where the seizures are taking place, depending if they're temporal lobe or if it's somewhere else in the brain, the chronicity of the seizures, how long they're lasting, how many. But then the actual big consideration is, the medications for many seizures can actually they slow down your thinking. And so really as a neuropsychologist, you have to tease apart and understand where those seizures are taking place, look at what medication someone's on, and understand that it's all part of the picture. Um, so in terms of differentiating if it's an encoding problem versus a storage problem, um, usually it's if at a basic level, if it's most time it's probably going to be more like an encoding problem than a storage problem, unless the hippocampus is implicated and those related structures, then we're probably looking more at a storage problem. But I guess that's for unless we're looking, but it also depends on what type of learning and memory. You can get really complicated if we're talking about procedural memory, then we're looking at other parts of the brain. um so complicated question, but I'd say we're probably more so leading to encoding than to storage issues for most, but the brain's all interconnected, so there might be disruptions with some of the storage aspects too. But my this isn't my total area of expertise in terms of epilepsy, but yeah, my sense without referring back to the chapter on epilepsy behind me, probably looking at more encoding than storage.
Um, Want to make sure we get like a wide variety of questions answered because
Sure.
we have so many. I think this is something we haven't touched on. It says, from your experience in clinical training and neuropsychology, how do the training models and clinical competencies differ between PsyD and PhD pathways,
Ooh,
particularly in preparing clinicians
yes.
for complex neuropsychological assessment and research?
Really good question. So, at a base level, a PsyD and a PhD are both doctorates. They are very different in terms of what the educational standards look like, your competitiveness for internships or residency match, and kind of what they train you for in the outside as well as the competitiveness to get in look really different. So most PhD programs are accepting 1 to 3 students a year. Sometimes they might have a cohort of 5 or 6, but if there's a cohort of 6, typically there's a one student on the neuropsych track, and maybe the others are looking at maybe a child psychology track or an adult psychology track or a health psych track. So for neuropsych, you might be the only 1 or 2 neuropsych track students in your cohort of 3 or 5 or 6 students. So it's highly competitive. And part of that is most of these programs are providing tuition remission. So you're not paying for your education and you get a stipend. So your research is you're getting anywhere from, I don't know, 18 to $50,000 living stipend based on the work that you're doing as a researcher or a teaching assistant. Um, so as a PsyD, uh, you have to pay for the education and you don't get a stipend. So you are paying for that program, and it is much less competitive to get in. So they might be accepting anywhere from 20 to 75 students in a group because they don't have this research allocation, because you're paying to get in. So PsyDs are historically less competitive, which also means that they are, if you're in a large metropolitan training area, they are less competitive at the externship level. So most PhD students are training at the academic medical centers and the VAs in these externship or practica, the 2 to 3 days a week. That doesn't mean that PsyD students don't train there as well, but they might be a little bit less competitive at some of those sites, and tend to be more community mental health centers or private practices. Um, Society de-emphasizes research. You're typically not collecting your own data. There's not typically faculty in the program doing research. It is much more heavily focused on coursework and, for the most part, your clinical skills. Whereas your clinical PhD program, it is a scientist practitioner. So you're trained as a scientist and a clinician, and different programs might be practitioner scientist or scientist practitioner, emphasizing one over another or be equal. But the idea is that you need to know, not that you're going to do research your whole life, but you need to know how you would go about research so that you can critically evaluate it to be a good consumer of research, to be a better clinician. So the theoretical orientation is a little bit different too. And that's the focus of a PhD program, is really having that scientist lens on your clinical skills, so that you can have a lens on evidence-based practices for your clinical work. So I'd say probably more than half, I don't know what the statistic is, of clinical neuropsychologists probably come from PhD programs, but there are many clinical neuropsychologists that come from PsyD programs. The match rates for our internship or residency just came out from phase 1. Phase 2 happens, I think, in like a week or two. But the PhD students were much more competitive than the PsyD students. So they're getting more competitive, what's typically known as like higher quality training sites that are more competitive, more likely to match at an academic medical center or at a VA. And clinical neuropsych internships are some of the most highly competitive internship sites. So it increases your likelihood of matching. And with a clinical psych or clinical PhD, you are not a doctor till you finish internship, which is different than med school, where you do your residency after you're a doctor. So here in this field, you have to do your residency to become a doctor. So if you're delaying or less competitive on your internship match, and you have to delay a year or you don't match, you can't become a doctor until after. And then again, it can impact your then competitiveness for this postdoc. So it's not to say you can definitely go through the PsyD process, and many do, and become a clinical neuropsychologist. It's a little harder, and the types of programs I would say that draw clinical neuropsychologists tend to, on a whole, be a little bit more data driven and research oriented. May not do research forever, but that tends students tend to more likely come from that PhD track. So there's pros and cons to both. I obviously have, you can tell, a particular bias that I'm coming from a PhD program, so I'm going to hold probably that bias and that lens. But I encourage, if that's something you're interested in, to talk to students who are PhD and PsyD, and then people who have come on the other side, to discuss some of kind of the pros and cons, and maybe some of the challenges on either end that they've experienced, to know what you're getting into, both before you take out debt for graduate school, or kind of set yourself up on a track that might have different implications you might not realize till kind of down the line. It's a long journey. Yeah.
Thank you for going over both of those. I think that's
Yeah.
helpful. Um, I have a question. I know you mentioned talking to family members to gather information about
Yeah.
someone's behavior, and I would imagine kind of specifically maybe for like a child who's now taking care of their adult parent, that they're kind of like comes to the forefront of their mind that this runs in their family. And
Yeah.
what kind of information would you give them if they're worried about managing those risk factors, or if this is going to happen to them
Yeah.
in the near future?
Yeah, that's a great question. So that's the psychoeducation piece is really fun as a clinical neuropsychologist, because a lot of people and the public is not well informed when they think dementia equals Alzheimer's disease at a 1-to-1, and it doesn't. Dementia is a big umbrella where there are many different types of etiologies of just dementia, and some are progressive or neurodegenerative, and some get worse, and some do not. Some are more lifestyle based, and some are more based on brain pathology that gets worse over time. Most people with Alzheimer's disease have a sporadic presentation where it is less related to your family history. And they're actually only, it's the early onset where it onsets in your like 40s to 50s, and signs show even earlier. And those families are very acutely aware that early onset Alzheimer's runs in the family, and many researchers are tracking those families. It's the early onset one that has the very strong genetic loading. There's some other diseases like Huntington's disease that are dominant that pass down and things like that. So a neuropsychologist can really help talk through um, where the true kind of risks and risk factors and protective factors are, and what a lot of the research actually shows with dementia, and what I talk to many patients or patients' families who are concerned, is that some of the biggest risk or protective and risk factors for dementia have absolutely nothing to do with your family history. It's your cerebral and cardiovascular risk factors. So physical activity and keeping your body moving is one of the biggest protective things you can do. We're even starting to move at any time, and it doesn't need to be going to the gym. It might be, it's just any types of walking or physical activity, even little bits can make a really huge difference. People who adhere more to the MIND diet or the DASH diet. There's a lot of research coming out of the Rush Alzheimer's Disease Research Center in Chicago. A lot of research on those types of diets, kind of that heart healthy diets. Um, Again, those same blood vessels go up to the brain, and a lot of these cerebral and cardio risk factors and protective factors can either take coins out of our brain's piggy bank or put coins in. And so we talk about that. We talk about the benefits of social support and kind of continued brain engagement. But the biggest thing that I explain to patients, their family, related to these risk and protective factors in terms of putting these coins in, if you go with that analogy, is that even if you had, say, the plaques and tangles for Alzheimer's disease that were sitting there in your brain or going to be there, if you're really focusing on these great protective factors, it's going to delay the clinical expression of the disease and potentially reduce the severity. Um, I've seen patients who had frontal temporal dementia and Alzheimer's disease in their 80s, but weren't showing clinical symptoms until well into there, when we know FTD actually presents more commonly in like your 60s, because they were so focused on good heart health, eating a healthy diet. They were someone who were still working actually as a clinician up until later adulthood. They were engaging in social activities, as brain health, keeping their body moving. And so all of these things that even if there is going to be some type of progressive thing that happens later, you can put coins in your brain's piggy bank. And the literature shows that that is actually significantly more protective and you over these modifiable factors than these non-modifiable ones, like your gender or your race or ethnicity or country of origin, or if there's a genetic loading essentially for something. And most of the genetic loading for Alzheimer's disease really impacts that early onset, and most of the late onset is sporadic. So we talk through all of those pieces. Yeah, it's a great question.
Thank you so much. Um, I want to be mindful of time. I'm so sorry, folks. I know we had a bunch of questions in the chat that we didn't get answered, but I do feel like we hit a good variety of the ones that we were seeing most frequently. So I'm going to hop into our wrap-up slides. All right. Once again, want to start off by thanking Dr. Ellison. That was a beautiful presentation, and we appreciate you sharing all those resources with our team. I know Dr. Ellison mentioned a few things, such as the book, and access to those slides. So if you need any of those things, please be sure to send us an email so we can coordinate and get that for you. We encourage you all to take some time to reflect on anything that you heard here today. If you had your favorite moment from session or one idea you want to explore next, and if you'd like to, you can definitely share those insights on LinkedIn, get your professional network started, and we also love to hear any feedback from all of our sessions. Um, uh, LinkedIn is a professional social media platform, so be sure to kind of update your profile on there and give Pre-Health Shadowing a follow. We love to connect with y'all over there and keep you up to date on any professional opportunities that you can partake in to expand your network and learn more. Again, if you're interested in being a part of pre-health shadowing, there is a link in the chat. You can register to be a volunteer on our website. It is 100% remote, and we are looking to expand our team. If you can donate, please do. Even $1, 50 cents, any little bit helps, as well as donating your time. That's a big one that we'd like to push for because you can do it remote, and we will work to accommodate your schedule the best that we can. Also, sending this QR code to your network, anybody you know, any other organizations that you volunteer for, if they're looking to help support us, please do share. When it comes to your post-quiz assessment, that is currently live on Dr. Ellison's course page, so please head over there. It is up to take, it is a 10-question multiple choice quiz based on the presentation. You do have two chances to pass it with a 70% or higher for verification of your hours. If you have any questions or trouble, feel free to send our team an email, but that is ready for you all. If you missed any part of our session today, or if your Wi-Fi cut out, you can see Dr. Ellison on any screen near you on YouTube. We have a full playlist there of all of our sessions, and feel free to watch any of our previous sessions as well. And be sure to catch our sessions every week. They are listed on our website, and we are so thankful to have had you all here. Again, Dr. Ellison, thank you so much. So excited to have had you. And if you need anything else, please let us know.